Suraj, want to go ahead and get started?
Absolutely. Good morning, everyone. Thank you for being here for our cardiology grand rounds. My name is Suraj Mishra. I'm one of the chief cardiology fellows, and pleased to introduce our speaker today, Dr. Mohammed Makkiya. Dr. Makkiya specializes in advanced cardiac imaging and currently serves as the medical director of the Hypertrophic Cardiomyopathy program here at VCU. He has multiple ongoing research activities in the inpatient and outpatient setting for cohort studies and clinical trials. And he's been working on a variety of projects with an emphasis on cardiac imaging research and clinical research in hypertrophic cardiomyopathy patients. In his time here, he's built up the hypertrophic cardiomyopathy program at VC Medical Center, which continues to really grow tremendously. We're very grateful for Dr. Makkiya's expertise on this topic and look forward to learning from him. At the end of the lecture, we'll leave some time for some questions. Please submit them via the chat function on Zoom as they arise during the talk. We're pleased to offer both CME and MOC credit for our Grand Rounds conference series. So to claim credit for today's session, text that code shown at the beginning, and it'll be at the end as well to the number indicated. I'll now turn it over to Dr. Makkiya. Thank you.
Thank you, Suraj, for the wonderful introduction. Good morning, everybody. Welcome to another Grand Rounds at VCU. My name is Mohammed Makkiya. I'm one of the non-invasive imagers at VCU, and I run the Hypertrophic Cardiomyopathy Clinic. So I have no disclosure. Today, we're going to talk about hypertrophic cardiomyopathy. We're going to talk a little bit about history and epidemiology of the pathology. We're going to define and talk about the new guidelines, a little bit talk about genetic, clinical manifestation, complications, and management. And then we'll finalize with the future and ongoing studies in the field. It's a very active field right now, and VCU is participating heavily in that, and future management options. So before we start about ACM, this is some history about it. It was Dr. Donald Tier and St. George Hospital in London was the first person to write about hypertrophic cardiomyopathy. This was in the 1950s, almost 70 years ago. He was a pathologist and was the London coroner. It is interesting that Dr. Tier was able to describe ACM in a case report and small sets of case series very accurately. He recalled what we know now in the field and working throughout today. In the figure on the left, he talks about a localized thickening of intraventricular septum. And the next figure on the right, he shows histological slide of myocardial disarray, which is a disorder arrangement of the muscle bundles. At first, he thought this was a myocardial tumor, but when we looked at the biology of the disease, we realized that this wasn't the case. In the past, HCM was called many different names like idiopathic hypertrophic subaortic stenosis or hypertrophic obstructive cardiomyopathy. Now, the most exact and up-to-date name is hypertrophic cardiomyopathy. I just want to mention, of note, this paper received more than 1,200 citations. So HCM is passed down in an autosomal dominant pattern. It affects the sarcomere and its links to mutation. Involves the nucleotide sequence variants in 11 or more genes that codes for protein of the thick and thin myofilament contractile components of the cardiac sarcomere or the Z disc. The beta myosin and the heavy chain and myosin binding protein genes are the most involved, and it's the target of the new therapies once we understand the pathophysiology. This slide shows the histopathology picture of how the myocardial is in disarray. On the upper left, we can see a normal histological slide of a normal myocardium. On the cardiac myocytes are very lined up in a parallel way, keeping their architecture. And there is a less white space, less interstitial space between the myocytes. On the other hand, in the right upper corner slide here, of a hypertrophic cardiomyopathy patient shows a pattern of disorganized myocytes that are not parallel to the first normal slide when you compare it, and there is more white space and interstitial space between them. This is called myocyte disarray, typical histological pattern in hypertrophic cardiomyopathy. This slide shows how important heart imaging and how it's changed over time to help us learn about HCM. This is interesting because the Marin family and Dr. Eugene Braunwald did most of the work that led to the development of these imaging methods over the years. As we see chronologically, in the 1960s, angiography and invasive hemodynamic data were first used to evaluate HCM. Then in the 70s, M-mode echo was introduced to measure the LV thickness and to identify the so-called systolic anterior motion of the mitral valve. Then in the 1980s, 2D was introduced and was heavily evaluated asymmetrical hypertrophy. Then comes the MRI in 2005 without contrast. And it wasn't until about around 2010 when the second generation of MRI that used contrast to improve the diagnosis and help measure the size of the left ventricle to find fibrosis and scarring and help in prognostication and making diagnosis. Here we can see how far the field in HCM has come since Dr. Tier first wrote about it in the 1950s. In the 1960s, invasive angiography was used, beta blocker and myectomy were introduced to treat obstruction. In the 70s, echoes were used, and in the 80s and 90s, family screening and alcohol septal ablation were first introduced. The Hypertrophic Cardiomyopathy Association, big association, important association, was first founded in the 1990s. Gene tested started in the 2003, and MRI technology, as I talked about, was introduced in the early 2000s. Then in 2014 and 20, and then 2020, the first guidelines about treatment, management, and diagnosis to family screening were introduced for HCM. And now we have HCM societies and meetings that that started last year. The first meeting was held last year, and we are meeting annually. So we talk about epidemiology, about the disease. It's a very widespread disease, as we see here in the red color part. Shows where in the world hypertrophic cardiomyopathy is most common, and you see it's everywhere. It has been described in 122 countries, which are about 90% of the world population, with a rate of at least one case for every 500 people affected. And as we are advancing in our diagnostic imaging and we know more about the disease, this has increased in recent literature to one case in every 200 people. So about 20 million people around the world are affected. The important thing to take away from this, that HCM is a disease that is not widely recognized, and about 90% of cases goes undiagnosed. It affects all races, all parts of the world. And there are many reasons they go undiagnosed, because like awareness about the disease, the fact the patient don't, most of like 50% of the patient, they don't have any symptoms of obstruction or SAM. Add to that, like not imaging or advanced imaging is not very accessible in every part of the world. So definition of HCM, HCM is defined as by the recent guideline in 2020, which with a maximal end diastolic wall thickness anywhere in the ventricle more than 15 millimeter, and the absence of another cause of hypertrophy in adults like hypertension, significant aortic stenosis, or athlete heart. For children, we adjust for body size and growth, and a body surface area adjusted to Z-score of more than 2 standard deviation above the mean. Limited hypertrophy in adults, or this goes like, we use less thickness to 13 or 14 millimeter, in patients who have a member or non-ACM phenotype, or if they have a positive gene test. These measurements are obtained by cardiac MRI mostly and echocardiography. We can also, which are the gold standard. Cardiac CT can be used in obtaining these measurements too. However, it's a not common practice, as they may require contrast radiation. Add to that the full temporal resolution of CT compared to other modalities. On this slide, we can see the known or different phenotypes of hypertrophic cardiomyopathy. On the left, foremost left, is the sigmoidal septal hypertrophy, the most common type, making about half of the cases. This is also seen in elderly patients or patients who have hypertension, which make it hard for us to diagnose ACM, especially since only 10% of these people with sigmoidal hypertrophy has been shown to have a positive gene test. We also see the reverse curve, the second picture. That trait is heavily associated with positive gene tests. And then the apical form, when the apex is affected, and responsible for about 10%, and has, if it comes later on with aneurysm, has the high risk factor for sudden cardiac death. And finally, the concentric or neutral form, which happens when the thickness of the whole myocardium is increased. So we talk about diagnosis now, imaging and hypertrophy. The first test was introduced as echo. Echo is easy to use, readily available. We can use spectral Doppler to measure the degree of LVOT obstruction and the severity and cause of mitral regurgitation from SAM. This helps us to decide how to treat cases with symptoms. And we can use stress echocardiography when we are unsure about the symptoms, or if we want to provoke an obstruction with exercise. It also has a role in risk assessments, prognosis, and definitely family member screenings. Transesophageal echo, we can use that sometimes in cases with poor echo windows, and definitely in guiding the treatment of septal reduction by alcohol ablation. Echo is the best method to use when you think about someone who has ACM and want to find out the pattern of hypertrophy. It helps figure out the global myocardial function. It finds out the presence of severity of LVOT obstruction. A significant obstruction usually defined when gradient is more than 30 millimeter mercury at rest, or 50 millimeter mercury when the patient is, when we do provocative maneuvers like Valsalva or exercise. Remember that we need to take accurate measurements of these velocities. The sonographers have to be very well trained at a comprehensive center, because you easily miss these LVOT obstruction. And it is known in the field that about 25 to 30% of non-obstructive ACM are truly obstructive when you do a proper stress test and provocation method. Echo also helps determine the degree and the direction of the mitral regurgitation, as well as intrinsic structure of the mitral valve and papillary muscle. Mitral regurgitation caused by LVOT obstruction due to SAM. Usually you get a jet, as you see here in the picture, directed posteriorly, predominantly in the mid or late systole, whereas central or more anterior jets should prompt further evaluation of an interesting valvular or papillary mitral muscle pathology. So also, strain has been used to risk stratification. I'm attaching here 2 studies that shows that strain can be helpful to give hints about areas of myocardial fibrosis, and strain values of less than or more than -10 can be a predictor of non-sustained VT. Then comes the MRI, which is the gold standard and very helpful tool as we are able to better diagnose and treat HCM. For example, it led to a better way to measure the size of the left ventricle, better way to figure out the risk of sudden cardiac death by calculating the scar burden, and to better recognition of different phenotypes expression of ACM, not recognized very well by echocardiography, especially the apical type. Different phenotypes of ACM are shown in these MRI slides. In picture A, you have the asymmetrical septal hypertrophy. Picture B, you have the mid-cavity apical hypertrophy, and then the so-called apical aneurysm, which can easily be missed by echocardiogram and without the use of contrast. And this can be a strong predictor if it's available for monomorphic VT and sudden cardiac death. Picture C, we can see a hypertrophy and abnormal insertion of papillary muscle in the anterior mitral valve. D, you can see the elongated anterior mitral valve, the so-called SAM. And E, you have hypertrophy of the papillary muscle and tendons. And finally, in picture A, F, there is no hypertrophy, but there is a narrow blood-filled myocardial crypt in the posterior basal left ventricle wall. This could be an evidence of genetic HCM in a family member who are like an early predictor of HCM, which warrant further evaluation and monitoring in the future. Some of the ways of that cardiac MRI is better than echo to differentiate the types of ACM is that echo sometimes miss. As we can see here, ACM can be focal, and as it can affect the anterior or infraseptal wall that usually hard to see by echocardiogram, but you can easily spot by and measure by MRI. Also, we can see how echo can miss, as I said, apical thickening in picture C, especially without the use of contrast. And once we do MRI, we can clearly diagnose apical HCM. And it's a very powerful tool, and I highly suggest that any patients who have HCM should get an MRI for proper diagnosis and measurement, and also for prognostication and setting cardiac risk assessment. Then we're going to talk about some basic genetics. As I said before, HCM is an autosomal dominant disease that affects around 11 to 13 genes that code for protein of the actin and myosin, thick and thin filaments. Almost half of them come from the thick filaments of the heavy chain and C-binding proteins. Important to know that about 60 to 70% of HCM who have the phenotype disease, they may be genetically negative when we test them. Part of the reason for this is that in the world of genetic testing, if you have a positive gene, you have to meet a lot of criteria to describe its pathogenicity. This makes it hard to say sometimes whether the gene is pathologic or not. And we may require cascade family tree testing before we came to that conclusion. Important concepts about genetics, specific gene mutation do not reliably predict the extent or location of LV hypertrophy, the clinical course, the prognosis, and utility of gene testing nowadays is only confined to screening family members, identifying phenocopies, and help to affirm the diagnosis of HCM in ambiguous cases. And gene has variable penetrance, so two family members with the same gene mutation can manifest or not manifest HCM phenotype, and can have variable expression. Two family members with the same gene mutation can have varying distribution and severity of LVH. As we see here, here is an example of how HCM can have different expression and penetrance. You can see the father, the proband have a MYBPC gene mutation and has focal thickening of the base of the septum, sigmoid septum. He has 4 children, 1 son and 2 girls tested positive for the gene, and 1 son did not. You can see that his son, who tested positive for the gene, has severe ventricular hypertrophy in a reverse curve pattern, which is different than the dad. His other daughter, on the other hand, has LV enlargement at the apex, and the third daughter has a positive gene test, but her MRI shows no signs of phenotype or hypertrophy. This means she's phenotypically negative and may not show sign of the disease for the remainder of her life. Then we're going to switch gear to clinical manifestation and complications. So what are the signs that you have ACM or symptoms? Most people with ACM won't have any symptoms and won't have any problems throughout their life, or symptoms may come incidentally from something else, and we come to know that they have ACM later on in their life. But the symptoms, if you are symptomatic from ACM, include shortness of breath, chest pain, dizziness, palpitations, maybe syncope, and these signs are usually not unique and can be caused by other heart conditions. Now, just like there are different ways that ACM can show itself, the clinical course and symptoms add to that possible complication can also be different, even though some patients have the genotype or phenotype of ACM. That may not necessarily mean they will have symptoms, or they may only develop mild symptoms, and they may have low chance of having complications down the road or not. So screening and monitoring is very important for these patients, as they are conditions and symptoms may develop early on or after on in life, or may never develop. Okay. In this study, Dr. Rowan and Marin followed around 1,000 patients with ACM. They found that only about 50% of ACM patients will have symptoms and complications like AFib, heart failure, or sudden cardiac death from an arrhythmia. Heart failure is caused about 40% of adverse events. It is important to know that LVOT obstruction is the cause of most common heart failure symptoms. About 70% get AFib, and usually that's later in life, and then about a large number, like 6%, have SCD. This was done on a patient followed from 2003 to 13. Here is the mortality risk of ACM. As we saw earlier, when the disease was first found, it has a high death rate of about 6%, most of which caused by arrhythmias and sudden cardiac death, the progression of CHF and stroke complications after AFib. Now that we know more about the disease, and if we developed early screening methods, ICD implants, heart transplant, and better way to treat symptoms, the overall death rate from the disease has dropped significantly and is now more like the overall death rate for the general population. Huge difference and improvement. With the arrival of the new disease modifying agents, we expect this number could go down even more if it's truly they have remodeling effects. Dr. Marin and his colleague did a study with the data from many sites in the US, Central Italy, and the coast of Italy to find out what causes death in ACM. It shows that the rapid death in ACM patient is caused by arrhythmias, worsening heart failure, and stroke complications. I want to point out something interesting about this histogram. On the x-axis, there is the age of ACM patient, and on the y-axis is the annual cause of death in ACM. The dark color box shows sudden death, while the shaded gray box shows heart failure, and the gray box shows CVA. It is interesting to note the bimodal peak of sudden cardiac death in a young age, and it becomes less noticeable as the people get older. Another important thing to notice that half of the death in ACM is caused by sudden cardiac death. And CVA caused by embolic events for AFib later on in life is the leading cause of death when you're in elderly patients. So that needs to be checked for. Then we're going to talk about the arrhythmias and sudden cardiac death and exercise. So the arrhythmia happens in this disease due to abnormal myocardium ventricular disarray, dispersion of refractory venous and re-entry. And exercise in the past, exercise was thought to cause deadly arrhythmia. Based on that international recommendation, advised patients with clear phenotypic expression of ACM to avoid competitive sports. Here, the work was presented from the USA on the left, and then from Italy on the right. It's clearly showing that sudden cardiac death in hypertrophic cardiomyopathy is usually not linked to exercise, and often happens when the patient is at rest or asleep, where the diagnosis is missed, more like a silent killer. Also, it is important to know from this graph that exercise-related deaths are more common in young people. So what do we know about exercise in ACM patients? Two studies I'm showing here. One is randomized study of exercise training in ACM trial found that about 16 weeks of moderate intensity exercise has a small but significant increase in exercise capacity. The study included older patients, about mean age of 50. There was modest increase in cardiovascular fitness and may be associated with the reduction in cardiovascular mortality. The other study looked at lifetime vigorous exercise correlated with favorable diastolic function in ACM patients, and it didn't show any association with ventricular arrhythmias. So exercise is favorable. High intensity exercise we usually tend to avoid because we don't have established evidence about that yet. And most of also in the young patients, these studies are coming up. So we didn't study a lot young population of people in relate to exercise and young athletes. So there are a couple of studies that are undergoing now, and we should have results from it soon. So who, when, and what we do to figure out if somebody with ACM has a risk of sudden cardiac death event. This slide is from the latest AHA-ACC guideline, which say that all ACM positive phenotype patients should be checked for symptoms, and risk of SCD should be figured out. We should get an EKG, echocardiogram, and Holter monitors versus longer cardiac monitor. Cardiac MRI should be done also, and we can exercise them to see symptoms, and if the symptoms is not very clear. And this should be done routinely throughout the years, as symptoms may change, as we talked earlier. Remember that the reason we do these repeated tests and scans, that patients with ACM have variable expression and penetrance of ACM, as I showed earlier. Here are the main risk factors that comes from the latest guidelines for sudden cardiac death. A history of CAC, or cardiac arrest, or ventricular fibrillation, or sustained VT is a class 1 indication for ICD placement and talk. A history of sudden cardiac death in an immediate family member, like parents, grandparents, basically siblings. Unknown syncope, not caused by other things like dehydration or vasovagal events, massive LVH, where the septum thickness is more than 3 centimeters. Now, there are some enhancers to these recommendations that's been added in the latest guidelines from the one from 2014, where patients who have LV apical aneurysms, these substrates have a high tendency to monomorphic VT and a sudden cardiac death event, or patients who have less than an EF, less than 50%, which signifies end-stage HCM. These are all class 2A recommendations for ICD placement. Now, the remaining risk factors, also the newly added, which is non-sustained VT, with a focus of more or faster or longer lasting VT, and extensive LGE enhancement is a Class 2B indication. But with the cardiac MRI, we can look at the LGE, which shows areas of scarring and fibrosis in ACM. We can also measure the amount of LGE and quantify the burden, what we call the burden of LGE, how much of the myocardium is involved. Keep in mind that about 40 and 50% of patients with ACM, they will have negative LGE, which is good prognostically, but they may develop it later on. This is an example of a study that looked at the prognostic value of LGE for figuring out the risk of sudden cardiac death in patients with ACM. Around 1,300 patients from multiple centers in the US and Europe, followed for several years after their cardiac MRI. It showed the prognostic importance of LGE in ACM. In the top figure, we can see that people with no or little LGE burden have better prognosis. And the histogram below, we can see that the amount of LGE load is related to the number of sudden cardiac death events. If one or more of the major risk factors are present, the physician and the patient should talk about it. The physician has to talk to the patient about the risk, the studies, the guidelines. The patient should also be shown or given educational tools, since this is a lifelong commitment, especially like you may end up putting ICDs in young patients. That's why I want to stress about the shared decision making in patients who have high risk for sudden cardiac death event to put an ICD, and this should be done at evaluated at highly specialized centers where you really can assess them vigorously, especially in the young population. Now we talk about heart failure as a complication of HCM. In this pie chart, we see that the severity of heart failure symptoms and prevalence increases with the degree of obstruction. When you see the salmon color, like is patients who have an NYHA class 3 and 4 symptoms versus the blue color is like NYHA class 1 and 2. Non-obstructive, they have more blue versus obstructive by provocation have less blue, and definitely if you have breast obstruction, you are mostly the symptomatic, and obstruction is a progressive disease, can progress with time. So how do we treat obstruction, or how do we treat HCM? The medical treatment for HCM is a mix of beta blocker, calcium channel blocker, and disopyramide with the introduction of the new myosin targeting agents. We start usually with a beta blocker, may add calcium channel blocker if we needed to treat symptoms of LVOT obstruction. Remember, we adjust the dose based on the symptoms. If there is intolerance to medication or difficulty to titrate the medication dose for symptoms like BP issue or side effects, we can try disopyramide, which showed good effect in treating ACM symptoms and LVOT obstruction. Remember that disopyramide may prolong QT and has a negative inotropic effect, so it's not advisable to use in patients with systolic heart failure, and it's preferably to use beta blocker with it. Last but not least, we have the new myosin targeted agents, which work very well and can be a good alternative to these drugs that I already talk about. So a year ago, the FDA approved mavacamten for HCM with patients who have LVOT obstruction based on the results of the study that I'm showing called the Explorer study. Mavacamten is a targeted inhibitor of the cardiac myosin. As we know, HCM is a disease of the sarcomere. As we see here in the middle image, we can see that there are too much interaction at the physiology level happening between the actin and myosin fibers in the ACM patients compared to normal patients who have less of this interaction on the left. Mavacamten, and this will lead to hypercontractility, and the hypercontractility with the thickness causes the LVOT obstruction. mavacamten act as a targeted inhibitor of the myosin that makes the myosin head more relaxed, so they don't interact with actin as vigorously as in the middle picture. This reduces the amount of cross bridges between the myosin and actin, which makes the muscle less able to contract and thus decrease the obstruction, as we see on the right figure, where myosin heads are less activated. In the Exploral study, among patients with hypertrophic cardiomyopathy, obstructive cardiomyopathy, mavacamten was superior to placebo. This medicine improved the functional capacity and health status as assessed by the KCCQ. And the KCCQ was worsened once the treatment stopped in these trial patients. On the secondary endpoints, mavacamten was associated with significant reduction in Valsalva or post-exercise LVOT gradients compared with placebo. A sub-study with CMR found that mavacamten was associated with favorable remodeling compared with placebo. This is to be determined with more long-term studies that we're going to look at. As we see here, the NYH class association after starting mavacamten shows better NYH classification of 1 and 2 and less 3 and 4 in the Explorer study. Here are the results of the safety profile of mavacamten on Explorer, and it's indicated it's very well tolerated by the participants. However, strongly recommend that mavacamten is a negative inotropic agent, and it is contraindicated in patients with systolic heart failure where their EF is less than 50%. These patients who start therapy should get frequent echocardiogram mandated by the FDA. It's a controlled medication. Only specialty pharmacy gives that. It's not available in every pharmacy, and frequent echoes should be done on a monthly basis or 3-monthly basis to evaluate heart function and to tailor the dose based on the presence of obstruction. This is another interesting study that presented on the last ACC meeting last year. 112 patients with obstructive HCM who are sicker with more NYH3 and 4 class symptoms despite medical treatment were randomly assigned to either mavacamten or placebo for 16 weeks. The left figure shows that most of the placebo group needed subtle reduction therapy, invasive subtle reduction therapy, while only 18% of the mavacamten group did. There was also significant difference in the NYH class with the treatment, and the right figure shows a significant decrease in LVOT gradient at rest and with exercise in the mavacamten or group. The NT-BMP and troponin also decreased in the treatment group. One thing to note about the safety profile of mavacamten is that only 2 of the 56 participants developed EF less than 50%, required brief interruption of MABA, and then they were able to be started back again on them on a lower dose after recovery of their EF. None of them had a significant drop in EF of less than 35%. Then, if medical treatment fails, what do we do? No matter how we try it with medications, then we switch to invasive subtle reduction methods. Here are the known invasive treatments. Dual chamber pacing is becoming less popular because the newer studies have shown the placebo effect is very strong. Subtle reduction in surgery, like myomectomy, is a good option for patients who have a low surgical risk or have a intrinsic mitral valve disease that you want to fix. If the patient is or you want to they have resistant AFib and you want to do a MACE procedure. If the patient is a good candidate for surgery or doesn't want to do it, we can do alcohol subdural ablation. On the left, we can see the hemodynamic chart. When a patient in sinus rhythm, there isn't a big difference between the LV and the aorta gradients. This is done basically in the cath lab. After a PBC, however, there's a big difference in the LV and aorta gradients. This is called a Brockenborough-Braunwald Maurer sign. On the right is the alcohol septal ablation procedure, where a small septal perforator is identified as shown by the arrow, and saline and with contrast is injected to match it with the basal septal LV muscle with the use of echocardiography, echocardiography guidance, whether transesophageal or thoracic. We identify the area that we want to ablate. Once identified, alcohol is injected to ablate the artery, and we see that post-ablation hemodynamic tracing is absent after a PBC. Now, if we want to intervene, which should we pick, surgery or alcohol ablation? Here is a study was done at the Mayo Clinic that showed there were no difference between myectomy and septal ablation in terms of total survival. However, as we can see on the left and below, on the right and below figures, alcohol septal ablation is linked to more gradients and later reintervention compared to myectomy. So which one to choose? We should know the limitation and we should know our patients to decide. That's why really a comprehensive referral like this should be evaluated by a comprehensive center to come to that decision. After exhaustion medical treatment, for example, septal myectomy, you have a thoracotomy, a cardiopulmonary bypass, 5-day hospitalization, and recovery period of several weeks. You have to have experienced surgeon. The learning curve is very important, especially in the outcomes of the surgery. Alcohol septal ablation, you should have appropriate coronary anatomy. Less effective when you have high gradients or high septal thickness. Can create risk for conduction block requiring pacemakers. Both can do that, but it's more with alcohol septal ablation, and you may need repeat intervention in the future. For AFib, with HCM, about 1,500 patients here in the US were followed over the period of 5 years. They found out about 20% of patients of HCM has AFib. This risk increases with age. 70% is paroxysmal, and 70% of the paroxysmal AFib they have more than one episode on 5-year follow-up. AFib recurrence is unpredictable in timing and frequencies, but tends to be more notorious than other reasons to have AFib, especially with treatment. Here we see the major studies done in HCM patients with atrial fibrillation. What's striking here is that not only AFib, is that only patients who have AFib, not on AC, without LVOT obstruction or heart failure or sudden cardiac death, is associated with 1.5% to 4% mortality in HCM. That's why it's very important to place HCM patients with AFib on anticoagulation, regardless of their CHA2DS2-VASc score. And finally, we're going to talk about future studies and management options. Many, as I said, HCM is a very active field, and we have a lot of future studies ongoing and upcoming in the field. And it's like Odyssey, HCM, Redwood, Discovery, Sequoia, Forest. The Redwood HCM, which, as I saw here, the slide of the Redwood study, which is released in January of this year in JACC, they showed that aficamten, which is also a direct myosin inhibitor, have less half-life than mavacamten, how it's affected patients with obstructive HCM compared to placebo. This clearly shows that LVOT gradients and NYH class and heart enzymes both got better with early on treatment compared to placebo. After this, there are 2 more studies that are coming to an end and ongoing. The Sequoia HCM, which is looking at how safe aficamten at different doses and how effective. and the FOREST HCM, which is looking at the long-term effects of aficamten on cardiac structure, remodeling, and disease, such as the size of the left atrium, the thickness of the LV wall, as well as how long the gradient reduction lasts over a period of, they are following patients for a 5 years period, which is a good amount, and we are really excited to see the results of these studies. So what studies being done and coming to VCU? So we just started the Odyssey HCM by BMS. We are currently enrolling patients. We have our first patient screen and enroll. Today is their first visit to get whether the medication or placebo. We have Discover HCM by also BMS. We start enrollment in 2 to 3 months. And we have aficamten in HCM by Cytokinetics. So this is upcoming to VCU. Hopefully, like we are in the screen, like in the management phase, and hopefully we should start this study everywhere by the end of the year or earlier next year. So Odyssey HCM, I want to talk about it. If you have patients, can be benefit for them, or you think it's a candidate, you can refer them to us. It comes after a phase 2 trial. This is a phase 3 trial, but it comes after a phase 2 trial, called Maverick study. The phase 2 trial enrolled the patients, small subgroup of patients who have non-obstructive HCM, was giving mavacamten versus placebo, and they found the BNP difference in both groups. There was a significant reduction in the BNP in the treatment group. Now, that's led to a phase 3 study called the Odyssey HCM, which is started. It's an international multi-site study between US, Europe, and Japan, that's evaluating the effect of mavacamten, the anti-myosin inhibitor, in symptomatic patients class 2 or 3, class 2 or more NYH symptoms who have non-obstructive HCM. We have to make the determination that they have non-obstructive HCM. As I said, when you have the resting, you should have a resting LVOT gradient less than 30, or with provocation, whether Valsalva or exercise less than 50. VCU is one of the study sites, and we are, as I said, actively enrolling patients. There are other sites in the U.S., all over the U.S., you please feel free to reach out to me if you have any questions, or if you have a patient that you think is interested in enrolling in the study, or interested to know more about it. We have a very good research team too, thanks to Jessica and Melissa, who are really, really helping out in enrollment and screening patients. Now, future interventions in HCM. So this is just came out. This is the first in-human transapical beating heart septal myectomy in patients with hypertrophic obstructive cardiomyopathy. Patients with OCOM were enrolled if they presented with drug refractory symptoms. They want more invasive procedures. This is done with mini thoracotomy with the use of beating heart myectomy device under echocardiographic guidance, without the use of cardiopulmonary bypass. Repeated resections were performed to tailor the extent of septal myectomy. This is done in human for sufficient avulsement of the left ventricular outflow tract obstruction and mitral regurgitation. They enrolled about 47 patients. 46 of them were followed up for 3 months. 42 achieved procedural success. The maximal LVOT gradient was decreased from a mean of 86 millimeter mercury to less than 20 millimeter mercury at 3 months. MR gradient was less than 1 in 3 patients and at 3 months, One patient died on postoperative day 10 owing to device unrelated reasons. Other major adverse events include delayed ventricular septal perforation, which happened only in one patient. Another, this is also possible future intervention. And this latest transitional research study done on pigs, they talked about a new type of myotomy that can be done without surgery and similar to early surgical treatment for obstructive HCM. This is made possible by a new technique called intramyocardial guide wire navigation and transcatheter electrosurgical laceration of the myocardial tissue, the CSAM. The results were promising. This is all done transcatheterally, like you do myectomy by transcatheter, and it's done in pigs. The results were promising. There was a relief of LVOT obstruction and less side effects from ventricular septal tear or high degree blocks. So this can be a possible intervention in the future. The more trials is upcoming in that regard. And finally, on the left, we have the radiofrequency needle, electrolyte needle is put into the hypertrophied IVC septum using percutaneous intramyocardial method through the apex. And this is done with the help of transthoracic echo. Then the part of the LAD artery leading, including the perforator of the septum, is ablated, less invasive technique than surgery. On the right, we have endocardial radiofrequency ablation of the septal hypertrophy. ERASH is an option to alcohol septal ablation or surgical myectomy for people with HOCM who are not good candidates for surgery due to their comorbidities or alcohol septal ablation due to their anatomy. ERASH doesn't depend on the anatomy of the coronary arteries and uses radiofrequency energy to ablate the septal target region straight from the left or right ventricular cavity. This may lead to significant and steady decrease in LVOT gradient. So a lot of future therapies are coming, especially in the medication remodeling phase on HCM. To summarize, and it's very, very active field. Also on the invasive front, we have a lot of upcoming surgical or mini surgical or transcatheter intervention in the future. Very excited about the field. This is thought to be, I heard one of the pioneers in this said, this is thought to be a permanent pathology, but they are very excited that this can be fixable. A lot of gene therapies I haven't added here is also targeted gene therapy at the gene level early on to prevention is also oncoming. A lot of studies is coming and undergoing for that. And with that, I thank you and I'm open to any questions. And this is the CME slide code for today's talk.
Thank you so much, Dr. Makkiya, for this really excellent and thorough overview on this topic. HCM, it's such an exciting field. I'd like to remind everyone, please place any questions you may have in the chat. I'll start with one, if you don't mind. Can you comment a little bit more about screening? With all these young athletes coming in, how can we best screen them? We hear on the news, more and more athletes, either collapsing on the field and so forth. So where are we moving towards that in that realm?
So excellent question, Suraj. Very important also question that patients who are athletes or going into competitive sport in college, should we screen all of them for HCM or not? In the US guidelines, the short answer is not, unless you have something or you have a family member, basically. In Europe, they are more on the screening part for these conditions. But if you don't have a lot of ambiguous symptoms or you don't have a family history, screening is not really recommended under the current guidelines. This may change in the future. And by to talk about screening, family screening for these patients who have a relative who have HCM, or immediate family patients who have HCM. This is very important to do. So if you have somebody who have HCM and the proband, you should refer them to a gene clinic. We have that at VCU. That's why comprehensive center is very important to refer these patients, because them and their family should be screened, evaluated, consulted about whether to do gene testing, and if the gene testing is negative, or inconclusive, we do like cascade screening or imaging techniques for their families, which is recommended annually or semi-annual or every 2 years for young patients, and this decreases in about like 3 to 5 years for elderly patients as you get older. As the disease is more notorious, you remember the disease is most of the time is symptomatic, and the arrhythmias is more notorious if it's happened at a young age.
Right. We have a question from Dr. Cook. That was an excellent talk, Mohammed. Thank you. Is there any experience using mavacamten in patients with apical HCM?
No, this is being studied. That's the Odyssey that we just started enrollment. Apical HCM falls under the non-obstructive HCM. Even patients who have mid-cavity, their obstruction at the mid-cavity, not at the LVOT or at the apex, who have these intercavitary gradients, and they have diastolic heart failure, very symptomatic from it. These also being studied with the Odyssey. So results will be available in the next couple of years once we finish, once the study is finished. So if you have any patients, or you think of any patients is interested, feel free to reach out to me or my research team, and we can happily talk with them and discuss this.
Great. I think Dr. Hyder, I was wondering if you could share that contact information. So we'll be sure to email that as well. Tashik Park, one of our fellows, great talk, Dr. Makkiya. Does mavacamten impact any other conditions rather than obstructive symptoms, such as decreasing the incidence of sudden death or AFib?
You know, like, to be determined. It's felt like as you decrease the stress burden of obstruction on the patients, definitely your LA remodeling can happen, right? To think about it, and that may like make the LA less smaller or less ballooned and less AFib. Even like the remodeling effect, very small subgroup on the Explorer showed that favorable remodeling. But you know, upcoming studies like the Discovery study, which VCU is part of it, which we're going to look at these long-term effects in regard to other arrhythmias, remodeling, LV dimensions and sizes, LA dimensions and sizes, and size, basically. Also on the other front from cytokinetics and the aficamten group, like the Forest study, as I mentioned, also looking at these on the long term. So that's why this is exciting. This is very active field that's happening right now, because we may have therapies we think, we don't know yet, we think can potentially help on the long run.
Well, great. Thank you so much. I guess, it's almost 8:30 now. So, thanks again, Dr. Makkiya. The CMA code is provided on the slide above there. And, with that, we'll end. Thank you so much.
Thank you, Suraj. And we'll share our line contact information. Any questions, feel free to reach out in person, email. And thank you for this opportunity.
Thanks so much, Mo. Fantastic job. Thanks for all you're doing for the people in our community, too. This is a great resource for really all of Central Virginia. So thank you for all your hard work in this area.
It's my pleasure. Glad to do it. Thank you, Dr. Humphrey.